Now, at this point, I'm introducing Danny Dunlop, except she's being represented today. Today, the part of Danny will be played by Tessa O'Dea. Thanks, Tessa.
Yes, so hi, I'm Tessa, not Danny. And I've got, again, like everyone else, a really challenging task of putting together a 6-minute presentation about a project that's been unfolding for multiple years now. And it was led by Danny Dunlop and Raymond Hugh out of anaesthetics, and it's implementing a pathway for rib fracture patients at Austin Health. Cool. So I'll just give you a brief background on the topic, but patients who present to hospital with traumatic fractured ribs represent a really high group, for risk of respiratory deterioration, and they're known to have quite poor outcomes if we don't get timely management and strong. We get, good. We can identify them early, and then we get strong clinical management happening straight away. And physiotherapy is a vital aspect of that management. And Austin Health isn't a major trauma hospital. It's not like the Alfred or Royal Melbourne where they see heaps of these guys, and so you get quite fragmented care, which with quite inconsistent management for this group of patients. And this all came to a head approximately 2 years ago, where there was a quick succession of multiple potentially avoidable patient deaths, which were reviewed at the Clinical Outcome Review Committee, and they all involved patients with fractured ribs. And so then around the same time, in 2016, there was some evidence published in a hospital pretty similar to Austin, which showed patients with chest trauma who were admitted to a medical ward had a 4 times higher risk of mortality compared to those that were admitted under a surgical bed card. And it was the combination of this evidence and the cases at Cork that helped gain a lot of traction in this area, especially with the medical stakeholders and anaesthetics in particular. So since then, a committee was formed to discuss this patient group, and it was led by anaesthetics and physiotherapy, or Danny and Ray, as you can see there, but it also had representation from emergency, intensive care, surgical, medical radiology and others. And the outcome of the committee was to implement a streamlined, multidisciplinary bundle of care with focus on timely and evidence-based treatment for high-risk rib fracture patients. And so this is the bundle of care that was basically developed. There's an EPIC guideline, so the Traumatic Fractured Ribs guideline that's been developed. You can go to EPIC and review it as you like, and this is a snapshot of one of the images from it. And now this information is disseminated through regular education sessions led by anaesthetics to the emergency department HMOs and to wards as well. But basically what it does is it utilises sort of risk factors to work out whether someone's high risk or low risk, and then if they're low risk, they identified in emergency and managed there and without needing admission. Then if they're high risk, they're triaged and they're admitted, and they begin this standardised bundle of care. And the bundle includes a mandatory surgical admission, a 24-hour tertiary survey, CT imaging, and referral to pain service and physiotherapy within 24 hours. And this is great for physio because it means that all of these high-risk rib fracture patients are identified to us on admission, which is vital for that timely management. Yeah. Cool. So over the last 12 months, what we've been doing is reviewing the success of the implementation of this pathway. We've done that via a retrospective chart review. So all medical records with a discharge diagnosis of fractured ribs were analysed between 2 periods of time. So we had a 4-month rollout of the pathway, implementation of the pathway, and then collected an audit of 5 months worth of data and compared it to 5 months pre-implementation of the pathway. And the primary outcome was to determine compliance with our bundle of care, and then there were multiple secondary outcomes like hospital length of stay, ICU admission, chest infections, etc. So what we found firstly was that the pre and post group data was really well matched, which is always important. And then the major finding among the high-risk rib fracture group was that there was a statistical significance in the increase in compliance with the bundle of care out of these 5 out of 5 key areas. So it's CT imaging for fractures, general surgical admission, tertiary survey at 24 hours, pain service referral within 24 hours, and physio within 24 hours. So it was the primary outcome, it was what we were after, and so it was a fantastic result. Yeah. So in regards to some of the secondary outcomes, from a hospital perspective, there was a trend towards a reduction in MET calls and UCRs observed, but we didn't really see any big impact on patient outcomes, and we think that's likely due to the study being a little bit underpowered to detect change at this point. Yeah, and we're hoping to collect more data in this to show benefit to patient outcome in the future. From a physio perspective, though, and sort of more on a quality note, one change that we noticed that it was difficult to quantify was the amount of time that physiotherapists saved, which we previously would have spent coordinating care for these patients. So it was often us sort of running around to the parent units, trying to get APS referrals or CTs happening, and all of that's now done by the pathway, which is a great time saver. So due to a very successful pathway coming in, it's been adopted and it's now standard care at Austin Health, which is fantastic. And as I said before, ongoing audits will be useful to make sure compliance is still happening and to collect more data on and determine impacts on long-term patient outcomes. And then the next step really is to try and bring in a Cerner care set so we can get some automated blanket referrals to physiotherapy. But there's been some technical issues, as standard. I don't know anything IT, I look to Jolene. And so that means we've got this ongoing rollout of anaesthetics having to do ongoing education at the moment. But yes, hopefully that will be a bit more streamlined in the future. And the biggest lessons we really learnt from this pathway, firstly, as multiple people have spoke about, measuring compliance when adopting a new model of care is really important if you're trying to measure effectiveness of uptake of the pathway, and sort of identifying any barriers that... Oh, I've got this. Determining any barriers that might come up along the way. And then the biggest lesson certainly that I learnt was that when you're implementing a hospital-wide change like this, multidisciplinary stakeholder support is vital for success. And this project would not have been such a success if anaesthetics didn't have as much buy-in and weren't as invested to change as we were. So it was great. Thanks.
Thanks, Tessa. It's always a challenge to present someone else's story, so really good job. Well done, thank you. And also, I probably should have mentioned the reason Danny's not here is because she's somewhere else telling the story about this project.
I'm presenting this. So.
Yeah, so great work, thank you. And